Can I encourage you to sit down? Richard Lewis, Neil Dixon. Welcome everyone. It's great to see you all here. I think this is our 9th summit. It's my 9th as well. It's my 4th as Chief Executive. It's great at the Nuffield Trust. It's great to see so many old friends and indeed some new faces here. I used to enjoy this event probably more when I came as a delegate than I do being responsible for it. So I hope you will enjoy it. It's always very hard to plan these things because you're planning in advance in a world, as you know, that's increasingly uncertain. And I was just reflecting that last year I was admonished by a couple of people for being rather setting too pessimistic a tone. And looking back, they were right, because everything in 2016 went really well. I think we can... We can agree on that. You know, we had a funding plan based on the premise that we would go back, I guess, in the spending review. It wasn't premised on having Brexit. It wasn't premised on having people in number 10 and 11 who think that you can sort out the NHS like you can sort out the police. Although, if you've seen today's Daily Mail headline, that's not going so well, it turns out. Well, I guess they had a point. Perhaps. I was a bit gloomy. There are some reasons to think that we're challenged. The fact that the population is growing so much, and it's not so much the ageing that's the issue. I think some of the work that we've done over the last year about the extent to which the death rate is about to start increasing. You know, so more of us are going to die, and it's still the case that however good we get at prevention, it is the dying bit that's the expensive bit still, unfortunately. There's some big challenges about the governance model we've got. Until Brexit, I thought Andrew Lansley won the prize for biggest public policy disaster this century. He's still in there, I think. And what he's left us with in terms of the legacy of complexity, Donald Trump has nailed it, hasn't he? I don't know if you saw what he said recently. He said, "Who knew that healthcare was so complex?" Was that effect? I think what he said. I have to tell you, it's an unbelievably complex subject. Nobody knew that, apparently, according to him. So, perhaps some people in this room did. But all's not lost. You know, I think it would be it's foolish to deny that we've got some big issues. It's unhelpful to ignore the fact that people are making progress. I'm hoping that bringing people like you together to give you a bit of time and space to think about that, to share ideas with each other, to understand some of the evidence, and look at it with a critical eye. It doesn't always support our hypotheses, rather annoyingly. My favourite type of evidence is the one that confirms my prejudices. You're going to hear that in the next day and a half that unfortunately it doesn't always do that. There are some bear traps waiting for us, and there are some myths. The interesting challenge for organisations like ours and many of yours, actually, I guess, is in an environment in which it's increasingly difficult to get policymakers to listen. How do you make a difference? And last year we had a big think about our strategy, and one of the conscious things we did there was to focus much more on what I would call sort of street level policy. So as well as doing the sort of the policy commentary and speaking truth to power and calling out things when you find that they're inaccurate, there's a lot still to do to bring people together. We have I think a very successful group of CEOs of small hospitals called the New Cavendish Group, rather oddly because it's never actually met in New Cavendish Street, which is where our offices are. That's thriving. We've had a huge insight from them. We have learning networks for CCG chief officers as they start to think about what does it mean to be a CCG if your commissioning function has largely been transferred to an accountable care organisation. And we've been continuing with the Nuffield Trust tradition of convening people. Most recently, we did a seminar on Brexit, which is an area that I think on the whole the think tank community in health has stayed away from. For reasons that are quite understandable. Short summary, spoiler alert, no upside for health that we could find. Some really quite serious challenges. There I'm going, being pessimistic again. So maybe there'll be £350 million a week. There you are. My bit of optimism. although there's a fine line between that and complete lack of realism. So we're going to be doing some more work on that. That seems like an important area where we can perhaps at least influence things positively, particularly given the fact that it's very likely that in any trade negotiations and any negotiations that go on, health will not be at the table, and it will be a very easy thing to just say, oh, we'll give them that in any negotiation, and there'll be 27 or so of those going on in the next 10 years. I don't know if we'll have the stamina for 10 years of that, but we'll have a go, at least initially. We've still got a strong line of work in terms of evaluation using quantitative and qualitative methods of new models of care, and we've been getting really into thinking about how some of the models of care need to adapt, not just in the very popular areas of integrated care, which is pretty well populated with other people doing work, but we've done a lot of thinking about the future of acute medicine, how acute medicine interfaces with surgery, what do you do about general surgery in smaller hospitals. We've been looking at new models of paediatric care, and we've been running a virtual network with the RCGP, helping GPs think about how they scale up primary care, and I hope in the longer term change the operating model rather than just simply create a bigger version of GMS. All of those new models generally have some kind of technology underpinning, so we've been doing quite a bit of work looking at the opportunities from digital. We published a report back in March looking at the opportunities for that from digital technologies in terms of service provision, and we've also done work on how the digital landscape can affect patients and how they can take advantage of it. The other big driver is workforce, again an area which the think tanks traditionally have not done a huge amount of work on, although more has been forthcoming from a number of them recently. We've had a really nice collaboration with NHS employers about skill mix and new roles, and we're hoping that we'll do some more on that. I think we are still of the opinion that the workforce problem is as big as the financial problem. And there's a lot more to be said there. On the finances, Sally Gainsbury's joined us, John Appleby's joined us. We've done some really interesting analysis, Sally's analysis on what's been happening on the provider side and where do those deficits come from. I was particularly pleased with, but growing strength there, really about finance as well as economics, what's actually going on. And then finally, I suppose the other sort of street-level policy thing at the moment is the STPs, and there seem to be a number of translations of that acronym, including official redesignation of what the P means. I'm not quite sure where we are in the progression from plan to partnership, but we've been working with both individual STPs and with STP leaders collectively, and as part of the workshop today, we'll rerun a little exercise that we did with them called a pre-mortem, which is where you project yourself forward into the future and ask what went wrong. Very, very interesting exercise. I can't get away from this positive vibe. I'm really. You'll have to bear with me and help me out through the summit, which I hope you'll find both stimulating and useful. We've got international experience, we've got cross-UK experience, we're trying to encompass a range of areas. We typically don't, there's a number of areas we don't stray into in these summits. So we have a particular set of interests that we pursue, but don't let that stop you if you think there's something important that you want to say. I hope you enjoy the networking, which a lot of this is about. It's part of the action is up here, but quite a bit of it is in the breaks and over dinner. So without further ado, I welcome you to the 2017 summit, and it's a great pleasure, real pleasure actually, to introduce our first keynote speaker, who I think will lift us out of some of the focus on the NHS and get us thinking quite a lot more widely about some of the big issues about health rather than just healthcare, and how we can attack that in a different way, and indeed what we can learn from another country not that far away. So without further ado, Sir Harry Burns, welcome.
Thanks, Nigel. And I thought it was only Scots that were pessimists. Okay, so first 15 years of my career in medicine I spent as a surgeon. And for a significant part of that time I was a consultant surgeon at the Royal Infirmary in Glasgow, which served the most deprived parliamentary constituencies in the UK. And when I went to work there, within a couple of weeks I'd noticed something strange. They took longer to heal their wounds. Patients that had been used to operating on 7 or 8 days, the wounds were healing, they were able to get up and about and go home. It's about 9 or 10 days in the East End of Glasgow, and we attributed that to bad behaviour. Okay, they smoked too much, they drank too much, they ate the wrong kind of food, and that was clearly the reason. But the more I researched this, the more I discovered that there were significant biological consequences of living in a deprived area. We measured things like protein turnover. A patient with a cancer from the East End of Glasgow had a more vigorous loss of tissue mass than a patient from an affluent part of Glasgow with the same cancer at the same stage. There was something happening because of the social circumstances in which they lived. And that prompted a move into public health. And over the years in public health, I've lived through the sort of health improvement, health promotion doctrine, if you like. These people are hard to reach. We must find better ways of giving them information about how they are damaging themselves. It's more complicated than that. And because it's more complicated than that, we have to do things differently. And what I'm going to describe to you today is a bit of the journey I've been on over the years in thinking away from the fact that health is not just about the absence of illness, but it's about the creation of wellness, okay? That there is a science that underpins creating well-being, which is as rigorous as the science that says a lot of what we have to do is prevent illness. Now, I don't have time to go into that science in a lot of detail, but it involves neurobiology, it involves epigenetics, it involves stress metabolism, it involves inflammatory mediators and so on. It's all there if you want to find it, and I'm on YouTube. You can go and hear the full lecture. So, let's take Scotland as an example. We're told persistently that Scotland's health is a basket case because we eat the wrong kind of food and we smoke too much, etc., etc. So what we did was we looked back in history. This slide shows life expectancy in 16 Western European countries going back to 1851. 160 years worth of data. And you can see that for most of that time, the health of Scots has been as good as Western Europe. It's been right in the middle of, it's been the average. It's only since the 1960s that we've seen the rest of Western Europe pull away from us. And when you look at the rate of growth in life expectancy in the richest 20% of the population, it looks like that. And the rate of growth in life expectancy in the poorest 20% of the population looks like that. If the gap that had existed in 1960 had been maintained all the way through, we'd be in the middle of the European League, where we always have been. Scotland's poor health is a reflection of the fact that over the last few decades, the people at the lower end of the social scale have improved their health at a much slower rate than rich people. So what's been happening? We cannot explain that by smoking rates, by diet. We've tried, we've applied the statistics, and that only explains a proportion of the difference. So we began to try and look for different ways of understanding how the inequality has arisen. So we did a thing called, we measured the slope index of inequality. For each 5-year age band in the population, we plotted mortality per 100,000 population according to deprivation status. So here we have the richest 20% of the population going down to the poorest 20%. And you can reduce the data on that slide to a single number. Oops. How do I go back? We seem to have jumped a number of slides there. No, what's happened? Yeah, sorry, that slide's got out of kilter. You can reduce the data on that slide into a single number by subtracting the best from the worst and dividing by the mean, and you get a single number, which you can then plot to see how steep the inequality is across the life course. And that's what it looks like. Inequality shoots up between age 10 to 15. This is inequality in mortality. It's at its highest in the late 20s and starts to come down in the 40s. How can that be? because people die of heart disease and cancer, and it's old people who die of heart disease and cancer. But inequality in death rates is pretty low back there. And you can show that quite dramatically by taking heart disease mortality and subtracting that from all-cause mortality and plotting it. That's how heart disease, caused by diet and smoking, contributes to inequality in the Scottish population. Doesn't. So what is it that's causing inequality out down here? Well, it's drugs, suicide, diseases due to the use of alcohol, assault, and accidents. Drugs, alcohol, suicide, and violence. We're not going to fix that by reducing the saturated fat content of the diet. Okay? Those are psychosocially driven causes of ill health that are driving this decline in improvement of life expectancy by killing young people. Now, I've never seen that done for any other country. I don't know what it would look like if it was done for regions of England, but it's possibly worth doing. Because it points us in the direction that the problem is not too much illness, it's not enough wellness in the young population. And when you look for wellness, you can find a whole science of it. Salutogenesis, which is the parallel of pathogenesis, which we as doctors are familiar with as the causes of disease. Salus was the Roman goddess of safety and the Roman goddess of well-being. So over the years, the term salutogenesis for creating well-being has been coined. And this slide, which comes from colleagues at the Nordic School of Public Health, draws together 25 different theories as to how well-being can be created. And of course, I'll go through each of them one at a time. Yeah, well, maybe not, maybe not. Let's just pick a couple of them. Emily Werner was an American psychologist who studied the health of adults, who studied the health of children living on a particular island in the Hawaiian archipelago that was notorious for its alcoholism, its child neglect, its child abuse, and so on. And what she found was that 70% of the children lived essentially failed lives, but 30% did well. And the features that she identified as causing that well-being as they went through life was, first of all, their personality. Whatever caused it, they had a positive, optimistic outlook. Secondly, they had at least one family member who was sane and sensible and supported them. They had that adult to show them that how life should be lived. And they had a supportive community in their village or their town or whatever that helped them along. Corey Keyes, another American who talked about flourishing, found similarly that children developed into adults with a high level of success and well-being in their lives if they grew up with a sense of purpose, with a sense of mastery over their lives. They were in control of their lives, not other people. A sense of growing in the face of challenge, that challenges were there to be overcome. They had a positive outlook in life and an outlook that said, well, I'll make my own decisions. The guy who really did it for me, the guy who really began to point, because I was searching for a biological link between social circumstances and outcome. And Antonovsky was the first guy who began to tease this out. Another American who spent most of his career in Israel, where he studied the health of adults whose children had been in concentration camps. Again, the 70-30% rule seemed to work there. 70% of the adults were failed, lived failed lives. 30% were healthy, successful, and had positive family lives themselves. What he said was that the 30% who succeeded in life had acquired, before they experienced the concentration camp, they had acquired a sense of coherence. And a sense of coherence he defined as the ability to see the world as predictable and structured and explainable. A sense that you had the internal resources required to meet the challenges that the world threw at you, And thirdly, a desire to engage with those challenges. So it was the same as the others. So this is something that comes out in all these studies. Having a sense of purpose, having a sense that you can control the events that life throws at you, and an ability to understand and manage those events. But the one thing that Antonovsky said, and I remember reading this in the book, it was one of those aha moments. I sat upright, because Antonovsky said if you don't acquire a sense of coherence in early life, you experience a state of lifelong chronic stress. And in fact, the more you look into this, the more you find that Antonovsky was correct. Studies of looked after children show progressive increases in stress responses. Michael Marmot's study of the Whitehall civil servants, which shows very clearly that the least stressed person in any government department is the permanent secretary. Why might that be? Because he's in charge. He's in control. If a minister asks the permanent secretary to do something he doesn't fancy doing, what does he do? He gets someone else to do it. And it goes down the chain until eventually, at least in the Scottish government, all the crap nobody else wants to do lands on the desk of the chief medical officer who's permanently stressed. So control, sense of purpose, these are things that appear to be formed in childhood, and as Antonovsky says, sense of chronic stress results. And study after study has confirmed this. Now, just the ACEs study, which was carried out in California, and middle-class Californians at that. They looked at members of the Kaiser Permanente health system. They asked them about their experience of adverse events in childhood, and they related that to outcome. 9 different types of adverse event: abuse, neglect, parental absence through domestic violence, parental mental illness, parents being in jail. And what they found was that the more adverse events a child experiences, the more likely he is to fail in life. For example, a child who experiences 4 or more adverse events is 8 times more likely to become an alcoholic than a child who experiences none of these. About 12 times more likely to abuse narcotics. A boy who experiences physical violence at the hands of an older male is 8 times more likely to engage in partner violence when he grows up. 4 times more likely to be arrested for carrying weapons. Drugs, alcohol, suicide, violence. The origins of that lie in chaotic households. If you look at the pattern of morbidity that the Californians found in their chaotic households, slight increased risk of cancer, slight increased risk of heart disease, both of which we can attribute to the biological impact of adversity in early life, increased risk of drugs, alcohol, suicide, and violence, and you look at the excess mortality that we see in deprived parts of Glasgow compared to similar cities in England and Wales, pattern's pretty similar. Drugs, alcohol, suicide, and violence. The consequences of this are absolutely profound. The ACEs study did an economic evaluation of the impact of child neglect. They calculated that the lifetime cost of 1 year's worth of neglect in childhood was $124 billion, broadly equivalent to what the US economy spends dealing with conditions such as stroke and type 2 diabetes. So when I hear people say the health service is not going to be affordable in the future, well, let's start trying to make it affordable by doing the right thing. And by doing the right thing in early life, by supporting chaotic families. Because these kids will not grow up to be unhealthy. They will grow up to be successful in education. They will grow up to have jobs. They will grow up to pay taxes. It's a no-brainer, really. So what we talk about now as happening has been since the 1960s, when employment collapsed in West Central Scotland, the shipyards all began to close, the steelworks closed and so on, never adequately replaced by alternatives such as happened in the north of England, where housing was, traditional patterns of housing were destroyed as new towns were built and high-rise flats and so on, communities were just disrupted. What we see is what we're describing as an intergenerational cycle of alienation, which starts with chaotic early life. That chaos leads to mental health problems because we have been able to identify patterns through psychometric testing and brain scanning that shows that these kids are less well able to suppress inappropriate behaviour and are more emotionally labile, therefore more likely to be aggressive and anxious and fearful. They go to school, they behave badly, they are excluded from school, a policy which defies any kind of logical analysis. They fail in school. A lot of them will go to jail because they can't suppress inappropriate behaviour. They get into fights. And I go to prison quite a lot. Most of the time they let me out. And you talk to these 18-year-old kids and you ask them, what are you going to do when you get out? Well, I'm never going to get a job. I've got a criminal record. So what are you going to do? I'll sit at home, I'll watch telly and I'll drink. Because they have acquired a loss of any form of self-esteem, sense of control, sense of self-efficacy. What they don't figure into the equation is the fact that the girlfriend will have a baby or two. And those babies go into a workless, poor home where they will not be looked after appropriately. And then again, we find the system failing. A couple of days ago, I was at a meeting in London looking at child welfare inequalities, a project supported by the Nuffield Foundation. We heard from 2 adults who, as children, had been in care and who now find their children have been in care, and we find the system doing appalling things to them. One woman described the fact that she has 3 children at home. Social workers took a new baby away. She tries very hard to look after her children. She budgets very carefully. She has £50 a week to feed herself and her children. The baby was taken away. She has 3 visits a week to see the baby. If she doesn't take up those 3 visits, the baby is liable to be sent off for fostering. It costs her £5 each time she goes to visit the baby. So she has £35 a week to feed 4 people. £1.25 per person per day to feed her 3 children and herself. The man who spoke had a baby girl. He had been in care. He had a baby girl who he was desperate to hold on to. And the social worker, he says, social worker was great. She's let me keep the baby, but I've been told that I have to be there. If she turns up on an inspection and I'm not there, I am that baby's carer and the baby will be taken into care. At the same time, however, the Department of Work and Pensions have said, well, you're physically fit, but you're not available for work, so we'll take your benefits away. What's he to do? Our system is insane. We don't think of it as a coherent system for support. So we should do something about that. The causes of wellness summarised are here. Supportive network, feeling confident that you can deal with problems, and that, to my mind, is the problem. These people are overwhelmed by challenges that would overwhelm any of us, but they have less ability to rationalise, to control, etc., because they haven't experienced that as they grow up. This is the paradigm. One of my honorary fellowships is a fellowship of the Royal Incorporation of Architects of Scotland, because I talk about place and health a lot. And I asked an architect, what does that allow me to do? And he said, well, it allows you to draw pictures of houses and sell them for an obscene amount of money. So if anyone wants to buy this picture of a house, let me know. This is the paradigm we work with. The health service is like the man who lives at the top of a waterfall. And sick people float along, and he's the rescuer. And the public health system is the guy who says, why are these people falling in the river? And he goes up and finds the gap in the fence and tries to fix it. It's the wrong paradigm. It divides things into simple cause and effect, and it's much more complicated than that. Because we're all in the river all the time. We wake up in the morning, we feel well, but by the afternoon we've got a headache and and we don't feel so well. We're moving in and out of a sense of wellness. It's like being in a river where one side of the river's in the sunshine, you can float along and somebody's handing out mojitos and it's a very pleasant place to be. The other side of the river is where the crocodiles and the sharks are. The challenge is not to stop people falling in the river. The challenge is to teach people to navigate a complex system. So what we've done in Scotland is we've decided not to do the conventional thing. Conventional thing is a minister decides he wants to do X. He gets experts into a room where they talk for a bit. Civil servant takes minutes. They come back a few months later, they read out the minutes, they talk a bit more minutes are collected, etc., etc., etc. And eventually a report goes to the minister who says, OK, a civil servant writes an implementation plan, sends it out to the service, and something might happen. But it's never really going to transform anything. So what we decided to do some years ago was to act on this basis. That the people who have to deliver the change have to design the change. You can't expect them to be committed to anything they've had no say in shaping. How many times have you heard some strategy come out and a frontline worker say, if those smart Alex knew what I knew, if they had to deal with what I have to deal with? Okay? So we decided to tell ministers to go away. We'll fix this. We'll tell you when it's ready, okay? So we got, for patient safety initially, frontline workers in a room. We decided to transform childhood. We got 800 people from all health boards and local authorities in Scotland in a room every 6 months. And we got them to decide what was going to happen and to test it. And they would come back and they'd say, we've done X, we've done Y, that worked, but that didn't. Over a 3-year period, we had 1,500 small tests of change, small experiments, and at the end of the day, there were 20 or 30 things that worked. And what we've seen is stillbirth rate fall by 18%, infant mortality fall by 15%, significant improvements in engagement with health visitors and so on, that we think will lead to, by age 3 and 4 and 5, better developmental progress. And we now want to apply that whole place approach to do all of that working with frontline staff. So we've taken that east end of Glasgow, we're segmenting the population into, and we will pay attention to those living chaotic lives, using big data approaches to identify them. We're then going to work with frontline staff, and the fundamental change that we're going to get them to make is to fix people's problems, not quote rules and regulations to them. And I'll give you an example. Housing Association in Scotland, one of the biggest in Scotland, 75,000 rental homes, has a programme called Think Yes. All of their staff are told, if someone comes to you with a problem, you fix it, you don't tell them to go somewhere else, because they won't go. You don't give them a phone number, you don't tell them someone will phone them, they won't be interested. You fix the problem. And it all came about because the chief executive of this housing association was asked to go and see a woman who was living a really chaotic, difficult life. Perennial attender at her GP, at her A&E department, behind in debt, threatened with court orders, etc., etc., etc. And the problem was she had 2 autistic sons who couldn't be let out the house. They were with her 24/7. And the reason they couldn't be let out the house was there was no fence around their garden. They wandered away. They got lost. So he got hold of the housing officer and said, what about this fence? Oh, can't build the fence. Waiting on a health and safety assessment. Okay. And then once that's happened, we need an occupational therapy assessment. So how long is that going to take? Well, it could take months. Build the bloody fence and do it now. Built the fence, problem solved. And we keep finding stupid problems causing huge grief to these chaotic families. So we're going to get the whole system to act according to this Think Yes approach. The evidence from a number of places that have tried something like this are that instead of needs assessments being done and we come along and we tell you what you need, we work with the citizen to create a sense of self-efficacy. The evidence is that actually that transforms the way citizens interact, the way citizens control their lives, instead of this situation whereby actually we get the money and therefore we're successful because we've been given money to meet people's needs. The money needs to be out there in the community. Beacon and Old Hill in Falmouth did this. 2 health visitors started a programme. 2 health visitors with 5 local citizens started this and produced dramatic results over the years because citizens took control of their lives. Stoke-on-Trent did it and did an economic evaluation of its impact. Prior to implementing this approach with their most chaotic groups, they found that each person in that chaotic group was costing, in terms of the time of services, about £100,000 per person. After it was implemented, it went down to £2,000. Now, none of that money was savable, of course, because it was people's time. So there's nothing at the margin that could be moved, except maybe in the health service there might be less drug costs or whatever, might have freed up a few beds. We're not doing this to save money, we're doing this to save people's lives. But it actually has some significant impact. And the most stark impact was this: a huge reduction in antisocial behaviour and criminal behaviour in the area. So there is evidence that this is going to work. Einstein is quoted as saying that insanity is keeping on doing the same thing and expecting different results. Well, we're going to do things differently and see what happens. A lot of this system is stuck here. KPIs, 4-hour waiting times. Fail those, will just beat you about the head a bit harder. Okay? It doesn't reflect anything. We don't even know if the 4-hour waiting time produced better outcomes. In fact, there's some evidence from Australia that 4 hours maybe is too long to wait. Mortality goes up as you pass the 3.5 hours. I suspect that's because they are the sick people who are being resuscitated in A&E. But do we know that? No, we just beat people about because they fail the 4-hour waiting times. We've been talking about a quality improvement approach, but this is where we need to be. And there are methods for doing it. And I just want to finish. I was in Kentucky last week at a Robert Wood Johnson thing, and I looked around for famous Kentuckians, and one of them was Abraham Lincoln, which fitted nicely with this guy. Jimmy Reed, for those of you that don't know, was a communist shop steward in the Clyde shipyards, and when the Edward Heath government wanted to close his shipyards, he stopped him. Jimmy Reed took the workers in to work and locked the gates rather than taking them out on strike. And he was a fabulous orator, and he was on television every night absolutely flaying the government in the most eloquent fashion. And eventually, obviously, the government's PR folks said, get this guy off the telly, give him his money, he needs to keep the shipyards open, and he succeeded. Now, the ancient Scottish universities have a tradition where the students elect every 4 years the Lord Rector of the university, and in 1971 I was a medical student when we elected Jimmy Reed Lord Rector of Glasgow University. And here's the link with Kentucky. His rectorial address was reprinted in full in the New York Times, which called it the single most important public speech since the Gettysburg Address. And those of us who were in that room thought that comparison of Jimmy Reed with Abraham Lincoln was hugely flattering to Abraham Lincoln. It was about alienation. He saw what was going on in West Central Scotland in the 70s. All we've done is put a kind of medical analysis to it. He defined alienation as the cry of men who feel themselves the victims of blind economic forces beyond their control. The frustration of ordinary people excluded from the processes of decision-making. The feeling of despair and hopelessness that pervades people who feel with justification they have no say in shaping or determining their own destinies. That's what leads to chaotic families. That's what leads to the problems that lead to huge burdens for society later on. Until we sort that out, we can shout at the health service all we like. The fundamental problems are within families and the way we support families and the way in which, frankly, our rules and regulations destroy people who are struggling to do the right thing. So we're going to try and do that, and we're starting off in East Glasgow. Thank you. Thank you.
Well, I'm sure you've got some questions. I should have said that the Wi-Fi details are in your packs, and please tweet, hashtag NT Summit. There's plenty to tweet about there, I think you'll agree. I don't want to do the usual thing of have the chair ask the first question, so I'd invite people to put their hand up. There's roving mics around that will come to you. I think I see Naomi there. So when you get the microphone, which is just behind you, say who you are. And
hello, thanks very much, Harry. I'm Naomi Chambers from the University of Manchester, and we in fact shared a taxi last night. I'm quite glad I paid Harry's taxi fare. In fact, I think it was a worthwhile 15 quid.
Typical start.
I've not met him, so what I wanted to ask you, fantastic, and a real wake-up call for us all, because we have a very unequal society south of the border as well, and it has a huge impact on the experiences of people in terms of their healthcare and their health outcomes. What you probably haven't focused on particularly is what would be the impact if there was a massive investment in school education, because there's quite a lot of evidence that 30% of people that you talk about, those children who've had very chaotic, difficult childhoods, what can lift them up is an education that helps to take them away and lift them up.
Thank you.
I've had this precise conversation with John Swinney, who is our Deputy First Minister but Education Minister, and he has put a lot of money into schools, and I keep telling him, actually, the biggest determinant of educational failure is domestic violence. And what he needs to do is get homes in the 0 to 5 age range working well. And he also needs pull-through at the other end. He needs jobs for these young people to go to. He needs to give them a sense of purpose. One of the most interesting schools that I visit is a school that's started by arguably Scotland's richest man, a guy called Jim McCall, who owns a big engineering conglomerate. And he started a school, bought a factory, bit of it he didn't use. He created a school in it, and he takes 14-year-olds from with very chaotic histories. And he takes them in, and by age 6, and when he takes them in, they are all guaranteed an apprenticeship. He does deals with all the companies he works with. I want 5 apprenticeships from you, 5 from you, and so on. So they're given a very supportive environment, very high teacher-pupil ratio, and they're given jobs. And it's astonishingly uplifting to see that. So there's lots of different models here. But unless you get the bit before school and the bit after school right, then you can throw as much money as you like at the bit in between, but actually, I was speaking to a head teacher of a school in Glasgow who's been given an extra £500,000 to spend himself, and he said, actually, I'd far rather they spent it on making sure my kids had a breakfast before they came to school. Yeah. So it's complicated.
I think I see. Is it Dr. Modi? I can't see.
Thank you very much indeed. Nina Modi, President of the Royal College of Paediatrics and Child Health. So Harry, I'd like to congratulate you on... Can you hear me? Is that all right? I'd like to congratulate you on what you're doing in Scotland, because we've been watching this with a great deal of interest, and we would love to see what you're doing in Scotland translated through the rest of the country. The 2 comments I'd appreciate your view on is, first of all, that I feel that grassroots activism is great and is important, but we also need national oversight to complement that, which is why the Royal College of Paediatrics and Child Health is calling for child health and well-being in all policies approach, because unless you have that focus, you're going to continue with fragmentation, and you're going to continue with the left hand not knowing what the right hand is doing. But I'd like to suggest to you too that the second important tenet of this thesis is that we should cease regarding health and well-being as commodities, but actually as very essential and absolutely core to the fabric of a resilient society that we want to build.
Yeah. Okay, the first part, we've been very lucky with our politicians. John Swinney, now Education Minister, was Deputy First Minister and Finance Minister before the last election. When we eventually let politicians into our early years collaborative, John came to do the typical 20-minute speech. He stayed for 5 hours, and he left saying, "This is the most astonishing piece of public sector reform I have ever seen." He is a huge advocate for this. So we've been very lucky with our First Minister, Nicola Sturgeon, and our Deputy First Minister, and all the other ministers who've taken the lead from that. Nicola Sturgeon has just given me the green light to start, and I hope she gives me more than a green light. I hope there's a few readies associated with it, to start what we're calling a Centre for Social Innovation that will oversee this kind of approach, but we've got her direct support. And when she's supporting it, the civil servants usually jump into line. So we've got that top-down cover. The thing is, they trust us to get on with it. And that's maybe a different kind of dynamic than what you've got down here. Your second...
Well, if we can take a few more
yeah,
comments.
sure. Yeah, sorry.
There's a load of
catch
people
up with the other
coming.
question.
Jeremy, we'll take two or three, I think. And if you could be relatively brief, Jeremy, that would be helpful. Yeah.
Jeremy Hughes from the Alzheimer's Society. It's really an observation about intervening at older age. We're doing a study with the National Centre of Gerontology in Japan, looking at the Dementia Friends and Dementia Friendly Communities programmes. And what we seem to be finding, both in the UK, where we've got about 200 grassroots developed dementia friendly community programmes, and in Japan, is that by developing that programme within a framework which we've established with British Standards Institute, you recreate for older people with dementia that sense of well-being, that sense of wellness, and then you can create the supportive environment that keeps them out of hospital. Is that something you're interested in and been looking at?
Yep.
Okay, I think we have Charles here. Do you want to just give the microphone there, and then we'll come to Andy.
Charles Alessi, Public Health England. Thank you, Harry, for that presentation. And it may be, I love your analogy about the river, because, of course, it carries the Lindström's River of Life. It's a twist of that, and I think that's great. It's really a question around what's so different about Glasgow in the 1960s as against Glasgow in the 1930s or Glasgow in the 1920s. Because if the change happened in the 60s, we remember the razor gangs. We remember, well, I don't, but I read about them. The 30s were the time of real, displacement and loss of power. So what is the fundamental difference?
Okay.
Good. Do you want to respond to that while the microphone moves down to
the
Rebecca
and
Andy? Yeah.
The big difference is you still had... People were still working in the 30s. There was still that. But it was the social cohesion, the tenements. In a tenement, people lived cheek by jowl. They shared the same toilets, Shigella dysentery figures were sky high, but they had neighbours. So if a young mother was struggling, there were older women in the close who would help her and teach her and so on. The 60s, there was a plan to flatten Glasgow and build high-rise flats and disseminate people. And it was partially carried through, and then eventually it was stopped. So there was a big difference in destruction of social cohesion.
A couple more quick points. Andy?
Andy Cowper from Health Policy Insight. This sounds like a great initiative. What were the practical problems that you came up against first, and how did you solve them?
Okay.
Yeah.
So...
Yeah, you better answer that while the microphone goes to Rebecca.
Still got the Alzheimer's one to go, but we're in the process of doing it. When initially the civil service, when we proposed this Centre for Social Innovation, the civil service said, right, we will plan it. And the first year of planning was all about training people. I said, stuff that, we're about doing things. And we don't know what we need to do until we're actually out there. And I go out and talk to the housing officers. I don't trust someone else. It's me they need to hear it from me. So we get housing officers say, what do you want to do that for? These people are all drug addicts and alcoholics. If we ask them what they need, there'll be a big long list and costs will go through the roof, and I have to show them the evidence and so on. So there's that kind of resistance. It's unusual, because what we're doing is we're giving people permission to act out of role. And the other thing we have to do is make sure that the leaders of these organisations are there to cover their back. And we're lucky, because we've started in a place where the leaders of the organisations involved are saying, yeah, we need to do this. So it's a bit about leadership, and it's a bit about convincing battle-weary troops that they can make success out of where they are.
Do you want to deal with the Alzheimer's?
The Alzheimer's one, that's a really fascinating one. The brain changes that you see as a result of chaotic early environment involve same bits of the brain that are implicated with Alzheimer's, particularly the hippocampus. Jack Shonkoff, who runs the Centre for the Developing Child, is chairing a group in the States looking at evidence-based interventions that will reverse the shrinkage of the hippocampus. Mindfulness, physical activity, being surrounded by a supportive environment, friends and so on, all of which have resonances with Alzheimer's. So my guess is if we do this, we'll actually help reduce the incidence of Alzheimer's, because these, we've measured brains of hippocampal volume in deprived Glaswegians, and they're smaller than in the affluent ones, so they're already partway there. So the same thing is true with older people. And when we're talking about chaotic households, we don't just mean chaotic households with children.
We've got probably time for one last comment, which I think, Rebecca, you got in first. So,
Rebecca Rosen from Nuffield. We have a fantastic programme up and running called the Family Nurse Partnership, which deals very, very intensively with teenage mothers during their pregnancies, and it totally addresses the range of social and emotional determinants that you highlight as causing ill health. They are under intense pressure now as the financial pressure grows with CCGs disinvesting from the programmes. Yeah. And I guess the question is, how can we get people, given the extraordinary strength of evidence of the long-term consequences of neglecting these things, how can we get people to hold their nerve and continue to invest in evidence-based interventions like that?
Absolutely. We've got FNP as well, and it's expensive, and therefore people are anxious about it. But you're right, it's utterly transformative of the lives of the teenage mums that they're looking after and their babies. And I've seen it with my own eyes, how it works. How do we get people to hold their nerve? I mean, it comes back to the point, health is not a commodity. Health is, it's a matter of justice for people that we should do this. So no matter how expensive it is, we should still make that argument on a human level, not on an economic level. So the one problem about FNP is it's difficult to get the data, because it'll be 5, 10, 15 years before we see the clear outcomes in a traditional sense. And there's a relatively small number of mothers benefit from it. So we need to collect the data at scale and make sure we follow it and make sure nothing happens to it until we've got the data that tells us what the outcomes are. It's a hard one, but we're not giving up on it.
I think we could do this all morning. There's no point waving at me, Melia. We're done. I've already failed in the first job of chairman, which is to keep us to time. But I hope you agree that was just phenomenal. Thank you very much. Harry's around for a little longer today, so you might be lucky and be able to grab him. I'm going to try and find out why the Challenging Families programme didn't appear to work, but you can tell me later. I will hold back. Let's move on. What's going on in terms of how the public are thinking? I'm going to introduce you to Anastasia Knox, who's Associate Director of Britain Thinks, who's going to give us a bit of an insight into public's perspectives on the NHS and social care. Do they think it's really complex, or is it just Donald Trump? Anastasia, thank you.
Great, thank you very much. Just a quick word on where the kind of insights I'll be talking about come from. We've done 2 rounds of work with the Richmond Group, initially in 2014 and then again in 2016, exploring public attitudes to the NHS, perceptions of change, where they want it to go. So I'll be talking a lot about that, but also drawing on some wider work. So where are they starting from? As we've just heard, I was asked to talk about perceptions of the NHS and social care. When we did that first round of work with the Richmond Group in 2014, we began by asking everyone to draw a picture of the health and social care systems. And this is fairly typical of what we got. You'll note the complete absence of social care. And really that reflects what we hear time and time again. The public don't really have a sense of what social care is. They don't really have an understanding of how it relates to the healthcare system. They certainly don't use the language social care. And the first time often they realise they need to pay for it is when they end up in the system. So to say it's low is, I think, quite generous. We are seeing some signs that that's shifting. Recently, when we did some groups towards the end of last year, people started talking about care for the elderly, care homes. But even that, of course, betrays quite a limited understanding of the social care system and what it is. So low understanding, and also really hard to actually know what's happening from a public perspective, both social care and NHS. Politicians, as in so many other issues, are just not trusted to talk about the NHS. They aren't seen to have the best interests of patients at heart, and often, they're seen as being driven by their kind of short-term careerism rather than any kind of long-term social altruism. The other major place that the public tend to go to for their information, obviously, is the media, and there is very widespread awareness of negative media coverage of the NHS, and that does play a role in shaping opinions. But the media itself is very much seen as having, again, an agenda, being driven by its own motives, and they're seen as sensationalist. So very hard to know what's going on. That being said, the NHS in particular is increasingly appearing on the public radar. So when we did some work at the end of last year, we got participants to write down 3 biggest issues facing Britain today. Brexit, very much dominant, as you would expect, but the NHS is on there, and we're seeing that in other sources as well. So the Ipsos Mori Issues Index in January had 50% of the population, I think it was, saying that the NHS is one of the biggest issues facing Britain today. That's the highest level since 2003, so a real jump in concern. What's driving that? Well, partly it is about those negative media stories. People might not trust them, but they do, months of screaming headlines do leave an impression. But also actually personal experiences. People are very reluctant to speak negatively about the NHS. But when you talk about what they've been seeing in their local areas, they're finding it harder to get an appointment with a GP, they're experiencing their appointments with consultants being shunted back. And actually, often they're hearing worrying things from people they know who work in the NHS, or indeed staff that they come into contact with when they go in. So, for example, someone said to me that they'd been in A&E just before Christmas, waited 4 or 5 hours, went to find out what was going on, asked a member of staff, and the staff just held up a newspaper that had some alarming headline on the front and said, "Didn't you know there's a crisis? What do you expect me to do about it?" And it's so different to what they expect to hear that it leaves a really lasting and deep impression on people. So where are the pressures coming from? Funding. The public is really aware that the NHS is short of cash, and that's seen to feed directly into staff shortages. They're aware of an ageing population as something that puts pressure on it. But they also see some other causes there too. So immigration, again and again, seen as a real concern and something that's putting growing pressure on the NHS. I think there was an opinion poll a few weeks ago that suggested that 68% of the population think that immigration places an undue burden on public services, including the NHS. That's really consistent with what we hear. There is, interestingly, some indication that Brexit might be taking some of the sting out of that, at least in the short term. The vote happened, it's been fixed. I think that's unlikely to stay that way, and it will flare up again as an issue. The other interesting thing we heard, actually, towards the end of last year, was some concern about the caring ethos of the NHS and questions about whether actually that's being eroded. People have enormous amounts of confidence in NHS staff. They really do. But there's a question about whether staff have the time to care, linking to that question about shortages, but also actually more fundamental questions about whether younger generations of staff have the same commitment. So again, personal anecdotes are really powerful here. So one person talked about how they had a new GP, they went to them to try and get some letter they needed, and they were told, well, I didn't go to medical school to become a social care worker. That, again, really undermines confidence. There is a real sense that these pressures are building, they're mounting. So in some polling we did last year, half the people we spoke to said that they expect the NHS to get worse over the next 5 years. And in groups we're hearing people talk about crisis, which is a real shift. 3 years ago, no member of the public was talking about a crisis in the NHS. And that sense of building issues does create some openness to change. People are willing to think about doing things differently. However, it's well known that the NHS is one of our most treasured institutions, and that affection is a real strength in many respects for the NHS. But when you're talking about change, it also really boxes the NHS in terms of what people are willing to consider. So because they love the NHS, they want it to be seen as outside politics. Because it's seen as outside politics, it needs to be seen as change needs to be driven by patient benefit, not by funding. Funding is seen as political. So they're not willing to accept a lack of money as a reason for reform of the NHS. It also means that they're not willing to consider certain changes. They have a really clear red line. So unsurprisingly, for most people, closing a local hospital, not something they're willing to consider. It's complete anathema still, as I'm sure you all know. So, on that basis, how do you engage the public with change? It's really hard. Public awareness of planned changes to service delivery is extremely low. I think I was feeling sunny when I wrote that. I would say awareness of the STPs in particular, completely non-existent among most members of the public. And by their own admission, most people are unlikely to engage until they see something in their local paper that crosses their red line, until they read about their hospital being closed or services being changed. And at that point, the NHS is already going to be on the back foot in a fairly substantial way. So how do you talk about change in a way that is engaging? Well, I think the first thing to do is to think about it, or to pitch it in terms of a response to ensure the survival of the NHS, to tap into that emotional commitment people have to it, and to use that as a starting point for a case to change. It's also really important that all arguments are rooted in terms of patient experience. We are doing this because it is better for patients, because you have better outcomes, that kind of thing. As I said, money, not going to wash. As I said, people are experiencing issues in their own areas, and they are seeing, difficulties with access. Playing that back can be a really helpful building block for change, for a change argument. It gives it credibility. It gives them something they can relate to. And giving reassurance the system will be recognisable to patients is so important. They don't want something that is fundamentally different, even if the way it actually operates behind the scenes is very different. They want to know they can still go to the places they know and they trust and they like, and get the care that they need. And finally, I think there's often a sense when we talk to the public, fairly or unfairly, that much public policy, not just about health, is kind of drawn up on the back of an envelope, finger in the air. And that means that it often is seen to lack credibility. So I think communicating that these plans have been thought through, people have been consulted, experts have been involved, that's really reassuring for public who are often, as I say, starting from a position of cynicism. In terms of what not to do, framing it as a cost-saving exercise, that's not just about saying the NHS is short of cash, so we need to. It's about looking at all the nuances of language. The public are very sensitised to words and spin and what things mean. If you talk about efficiencies, if you talk about streamlining, that's shorthand for cost-saving. Creating a sense that services would be cut. Most people aren't willing to consider that at this point. I think it would be very unlikely to move them to a position where they would. So that's very unhelpful. And implying that what's needed is a radical change or a revolution. It's much more helpful to talk about the evolution of the NHS and a kind of common sense progression from A to B. It's also very unhelpful to kind of look at the fine detail of kind of system processes. Most people have absolutely no interest in the nuts and bolts of what happens in the NHS. They don't care that changes to keyhole surgery mean that patients move from A to B in a slightly different way. They just want to know what it means for me and my outcomes and my loved ones. So trying not to get bogged down in that fine detail is really important. And finally, as I said, people know that we have an ageing population. They know that comes with certain implications for the NHS. But it's really important that anything that's kind of referring to those problems isn't pitched in a blaming way. It should be kind of avoid the finger-waggy judgment, because that makes people extremely uncomfortable. And the final point I'd like to make is really just thinking about the context in which people tend to consider accessing the NHS. So time and again when we go to groups and we talk about how people use services, they don't think about going to their GP to get a repeat prescription twice a year. They think about driving to hospital with their child extremely sick in the back of the car. And that makes access incredibly emotive. And it means that giving them all the facts in the world about how actually, closing your local hospital and moving services here is going to improve outcomes is not going to cut through that emotional frame. If we return to my picture, if you take out A&E from that, you're taking out 50% of their access to the system, and actually you're taking out the bit that they see as most essential and most urgent because it's most upsetting when they need it. It's also not enough just to have a really kind of trusted figure talk about change, although that does, of course, help. And by and large, the person that they trust most is a doctor, a frontline clinician with kind of hands-on experience. Changes to win over or to have any traction at all need to feel on an intuitive level like they will deliver benefits to patients. And some aspects of the changes that are being talked about at the moment do that. So if you think about care in the community, you talk to the public about that, and actually that kind of feels like a gold-plated service. Instead of trekking out to the hospital, I can go and see someone where it's convenient, it's much easier, I don't have to pay parking charges, all of those things. Many other aspects of the kind of reforms that are being discussed at the moment, A&E closures, local hospital closures, I think it's very hard to find that kind of emotional, intuitive sweet spot. And I think that's a real challenge moving forward. Thank you. I hope I've helped you regain some of your time.
Thank you. Good, thank you. Yes, you certainly have. That was stellar. Okay. I guess one of the questions that I speculate is, at what point do the public notice as a crisis? If you think the history of this is that we've had sort of everyone who's worked in the system knows it's been very difficult, and then you have Mavis Skeet, people may remember, at Leeds, one of the Leeds hospitals, or you have a Birmingham Children's in the late 80s. There's a number of these sort of pivotal events which sort of it's a non-linear process. I wonder what you're getting back from the polling and focus grouping you've been doing on that issue.
I mean, I think it's really in the last 12 months that they've started noticing the crisis. So 3 years ago, people would talk about, I suppose the first thing to say is a lot of the issues that people in kind of health policy see as huge, looming, pressing, urgent challenges for the NHS, most of the public aren't even aware of. It just doesn't cut through all the other things they have to deal with in their daily lives. So 3 years ago, when we did the first round of groups, the Richmond group, people said, oh yeah, I heard there was a problem in this hospital and I can't get an appointment with my GP, but they weren't triangulating those to come up with a kind of a burning platform. It's only in the last 12 months where they've had months and months and months of headlines. And it really is often driven by the press. They don't trust it, but it's unavoidable that they've begun to put those points together. And I think it's in the wider context of austerity, it's in benefits, all those kinds of issues that they're experiencing, that they're really seeing the problems arise.
Good. Thoughts and comments, and Neil. And then Stephen at the back. Neil first, then Stephen. Yeah, go on.
Thanks very much. A very interesting talk. It is coming up through now. I was just struck by your comment that presenting plans that are not properly considered can cause problems. The difficulty of the kind of perfect storm that I think a lot of STPs find themselves in at the moment is, first of all, some are a bit more developed than others. But if you are not then engaging with the public, then in the first place, you're probably not answering Harry's question about getting people to own the solutions themselves, including your clinicians. So that's the first problem. And the second problem is, if you don't consult at an earlier stage, people say, well, you've made up your mind anyway, so what is the point? This is all a farce. And I think that's a real challenge, especially when, to be honest, the actual form that is being developed is not actually at a point where people will know exactly what it'll look like and so forth. And again, evidence to support some of the things is in a developmental stage rather than an absolute stage of saying, we know this is going to work, we will develop these kind of services in that kind of way, and it will have that kind of effect. So I don't know whether you've got any answer for that fundamental conundrum.
There might also be people in the room who have an answer to that as well. You don't have to answer every single... Does anyone actually have an answer to that question in the room? How do you... Oh, someone actually is waving at me. Fantastic. No,
go ahead.
I don't know whether I've got an exact answer to that, but I think what helps in thinking it through is distinguishing between consultation.
So you need to say who you are. Sorry,
I'm Charlotte, and I lead the work of the Richmond Group of Charities. It's important to distinguish between consultation and co-production and communication of change. So what the public want to know is that the people who matter were in the room when change is designed. And clearly, as a group of patient charities, we would always argue service users need to be in the room when change is designed. But even if you do that, and you do it really well, and I'm not saying we are, but even if you did, you have to communicate this change to the vast majority of people who weren't involved in the consultation and who have no interest of going to the consultation events and who will never ever sit down in a community hall somewhere on a Thursday evening and talk about outpatient appointments. So I think it's important to do both. It's important to co-produce really well, but it's also important to communicate with the vast majority of people who only think of the NHS as a safety net they use very rarely. And that's what this research is talking about. It's not talking about consultation and co-production. It's talking about communicating to people who have very tangential involvement with the NHS but treasure it very highly because it feels like a really important safety net.
Thank you. Stephen.
Stephen Dorrell from... I'm going to broadly, I think, agree with Neil Dixon, which is just as well as the chair of the NHS Confederation agreeing with my chief exec. But I wanted to draw what I think is quite sharp distinction between Harry Burns in the first session telling us that health is related to social causes and the biggest causes of health inequalities in Glasgow is dysfunctional, chaotic families and so forth. In the second session, we're straight into discussing hospital closures. And as Charlotte was saying, if we want to build understanding of what health policy really means, it surely must involve discussion beyond the traditional health community, including, for example, local authority leaders. You quite rightly said STPs is a brand that means nothing to the voter. But actually, that's part of the problem, that local authorities are seen to be a different activity, nothing to do with health. But surely that's where we need to start to build the case for change with the people who are the elected local representatives of the communities these services are designed to serve.
Yeah, I mean, I would agree with that. What I would say is that people don't trust politicians. They also don't trust local government. So that's going to kind of have a similar starting from the back foot problem.
We're not starting from a very good place,
sorry,
clearly, are we?
With the optimism.
There's Angela. Can we get the microphone to Angela here? And then while that's happening, we'll come to...
Sam Everington, GP, Bromley by Bow. Did you find any difference between the four nations in terms of your findings?
So actually this what I should have said was England only. I wouldn't expect to find anything very different in Wales generally. Like when I've done work in Wales, it's been broadly similar. Scotland and Northern Ireland, I've got much less work in, so I'm not really able to say that though.
What's your hypothesis, Sam? Did you have a... Yeah.
I suppose what I've noticed over the last few years is differences, divergence of services. I certainly see this from, for example, in Northern Ireland now, the GPs want to hand in their resignation. There seems to be a much more cooperative approach, actually, in Scotland.
Yes.
There's been a divergence over the last few years, and that's the background to my question. But the question still lies, is there a difference, therefore, in the four nations in terms of how they feel about their health service and how their politicians are responding?
There's definitely differences in how the politicians respond, but that's probably a topic for another day. I'll talk to you at the break. Angela?
I was, like others, struck by the contrast between what Harry Burns was telling us about the causes of inequalities and what the public seems to believe, which is that what you really need to do is to be able to get into the car and go to A&E. And part of the reason that we're stuck there, I think, is because medical care has been oversold. People do not have a sceptical enough understanding of its limitations. How can we actually change? And that's a really fundamental change. The notion that more is better. How can we challenge that in the eyes or in the heads of the public?
I think the kind of public health argument to the public, when you go and you say, well, you know, the NHS should be helping people stay well for longer, it shouldn't just be curing them when they're ill, everyone just goes, yeah, well, of course, that's just common sense. I think that the problem is lots of things that people in the health system think are kind of really radical shifts are just met with kind of broad shrugs when you go and talk to a group of people in Leeds about them. So I think, you know, yes, people have very high expectations of doctors and or the health service in general. They have very high faith in it. But I wouldn't really want to see something that undermines that or that kind of shifts it in a different direction.
We do need to undermine that because it's misplaced. I mean, yes, we want to trust, but we also need to understand that, you know, medical care isn't all that it's cracked up to be. There are problems with it. There are problems like overdiagnosis, overtreatment, overuse, somehow or other, and those actually undermine people's sense of self-efficacy and ability to cope themselves, because the answer is always go and get a pill, go and see a doctor. So that does need challenging, but it's very difficult to see how we can do it.
Are there other really interesting? And are there anyone would like to respond to Angela's? That's got people. Alistair, let's go to and then we'll come to Naomi. Yeah, Alistair, do you want to?
It's Alistair Henderson from the Academy of Medical Royal Colleges. I mean, I'd actually support Angela very much about in terms of it's not. And it fits in very much with choosing wisely work that we're doing about sort of over-intervention, over-diagnosis. But I think it's slightly wider than what Angela says. It's not that just there's too much of that. It's an understanding that medicine won't solve everything. And all those other things that Harry... And that seems to be what I picked up, those concerns, coming out of those assumptions that if you go to the hospital, that will sort everything out. And that's maybe what we need to change, that actually, going back to what Harry said, it will be a lot of other things that will sort things out. And I don't know how you get that answer. I mean, you know, I was pretty positive after the Harry, but I'm rather more depressed now, sort of, because I don't know how you do that, and how you have those difficult discussions.
Have you had feedback from the Choosing Wisely campaign, Alistair, in terms of how much penetration that's getting beyond the professionals, would you say?
Yeah, I mean, it's relatively early days, but there has actually been... we've actually had website sort of hits and stuff from every country in the world, save 14, I think, sort of... Which is quite interesting, and huge lots of sort of interest. And again, a lot of very positive responses, aside from the sort of consistent theme that suggesting that the efficacy of PSA tests is clearly a feminist conspiracy being run by the Academy against men. I mean, was a rather strong line that we did have.
They're on to you then. Right. Good. Thanks, Alistair. Naomi, do you want to...
Yeah, I just want to slightly unusually challenge Angela around that. I mean, I do understand where you're coming from, which is about encouraging a healthy scepticism of the limits of medicine. But I want to take us back to what Anastasia has been saying and what people have been saying over many years, what the public have been saying over many years. And it relates to that kind of like really classic Maslow hierarchy of needs. And the first thing is that we need to have confidence that when we really need a doctor, we can get one. And actually there is a fragility and a chaos around the NHS, which we've had for many years, actually, both in primary care and secondary care, where there's been a huge amount of variation in terms of access. And until that basic foundation is there, and it takes the kind of worry away about how long I'm going to wait in A&E, or if I'm going to get an appointment to see my GP, then those other things actually are going to be second order.
Yeah, and one thing I'd just add to that very quickly is that most people don't go to their GP or to A&E thinking, I'm going to go and waste their time because I want to have a chat or I want some paracetamol. You know, they go because they're genuinely worried. So, yes, maybe you need something in place that gives them another way to address those concerns. I think it's slightly maybe unfair almost to the public to think that they're not extremely worried or in a heightened state of concern when they go to the NHS in the first place.
Neil, do you want to come in on this point?
That point or the one before? Yeah,
keep it going. Go on.
Neil Bacon from I Want Great Care. The question about how do we get the public to support change, it's not hard. I really don't think it's hard, but we have to do things differently. I could have been sitting in this conversation, all of us could have been, last year, the year before that. How are we going to get change? And it's back to the quote, if we keep doing the same things and expect change, we're idiots. So we live in an age now of reference, not deference. People don't defer, and that was said 5 years ago. People don't defer upwards, waiting for the experts. They don't believe the experts. We've seen that with Brexit, Trump, the efforts to get the public change. They do not believe the experts, especially in healthcare. It's an age of reference. We know how to make change, and we know how to make it stick, and it's to highlight, in the words of patients, the change that's already happening. There's fantastic work being done in the Vanguards. There's fantastic work being done in Yeovil. There's fantastic work being done in Barts. And tens of thousands of patients are talking about how it's better for them. When other people hear that, the man on the Clapham omnibus, which is essentially Twitter now and online, but also when staff see it, you start a real movement for change. We're not going to change by thinking, how do we do it? It's not up to us. It's showing those examples of change. One last point, the Cancer Vanguard going through. It's part of the Cancer Vanguard that you all know about. They're going to get real-time, continuous feedback on experience and problems from every patient and share it all publicly. It's big, it's brave, it's bold, but we have to think differently to get change.
We'll take a couple more points. There's Mike here. Was that Jocelyn? We'll stop on the way past Jocelyn here, yeah? And then on the way to Mike. Jocelyn, do you want to...
I just wanted to go back to this conversation between Naomi and Angela, really, and others, about the extent to which people are sceptical about medicine and aware of its limitations. And I absolutely recognise where Angela's coming from, and I think it's very important, but I don't think we should ignore the huge numbers of people who go to the internet first, or go to the internet second when they've seen somebody who doesn't help them. The huge number of people with long-term conditions who become extremely expert and very sceptical about the help on offer, and the millions who go to complementary therapies for help, particularly cancer patients, for help with symptoms and so on. So I think there's much more room for a real debate in these kinds of circles, actually, about why people I would suggest perhaps in this room, are rather reluctant to talk about the limits of medicine, except to other people who agree with them, rather than to go beyond that. And
we don't want to come out of our bubble, Jocelyn. That would be terrible. Thanks for that, Mike. And then I think there was Christian, and then probably we need to wrap.
Mike Farrer, independent management consultant now, and one of Neil's predecessors actually at the Confederation. Couple of thoughts. First off, I think we shouldn't assume a level of rationality or consistency about public opinion, in particular in respect of different questions about the health service. So I'm always struck by the fact that huge amounts of money, very, very large proportion of charitable donation goes to air ambulance, despite the fact that very, very few of us will ever in our lives need one, but we like to think if we did need one, it might be there. The other thing is that the difference about thinking about health service from health. And a couple of points. When I was in the Northwest, we did a study of people in Wythenshawe, and all their assessment of their own weights related to the relativity of who they saw in their next door houses and down the club. They didn't actually have any sense of a different population at scale. It was all relative, and they always underestimated their weight. That's one thing. Second thing is, coming back to Harry's point about addiction, I used to run drug and alcohol services, and people with significant problems always had someone else who was slightly worse than they were, which was the driving force for their own behaviour. So the point being that when we're thinking about public opinion in shaping a question about performance of healthcare, that's one set of questions. But actually, if we want to do something to address the kind of key things that Harry was talking about, it's a very different form of communication. And actually, opinions are formed in a very different way. And national surveys are probably pretty pointless, really.
Good.
Goodness. I think... No, that's fine. Polling has taken a bashing over the last few years. I think that, yes, you're right, there are inconsistencies in how people consider the NHS. That being said, you do hear, whether you're looking at polls or whether you're doing focus groups or whether you're doing depths, certain themes again and again. And you may think that they are not well informed or they don't know what they're talking about, they're inconsistent. You still need to consider it, because ultimately public opinion has the power to derail anything the NHS tries to do.
think we've got a twitted, or whatever the verb is, tweeted question.
Yeah, so I've been doing the Nuffield Trust Twitter account. There's been some quite interesting... I tweeted out your 5 kind of things that we should and we shouldn't do in communicating about change. And I think that one raises quite an interesting point, because there are two, about framing it as a cost-cutting exercise and creating the sense that services would be cut as both things that we shouldn't be doing. But isn't that going to imply that we're actually trying to pull the wool over people's eyes when that is exactly what is happening? And actually, when I tweeted that out, a few people have come back and said, well, this is exactly the sort of spin that actually is causing the problems in the first place. So how on earth do NHS managers deal with that?
I think there is a large group of people who will see anything that comes out as just cutting and spin, and hard to argue with that on one level. But equally, I think, assuming that people who work in the NHS do want to improve things for patients, which I think is a fairly safe starting point, it's not to acknowledge, it's not that you shouldn't acknowledge there are financial pressures on the NHS, but it's about saying, actually, we can do this and we can make changes that are better for patients. And that's more effective. It might feel like spin to some. I think as long as it's truth in it, as long as it's not just made up, then it's a more effective way of communicating.
Well, a little bit of housekeeping. We're going to break shortly now for coffee and tea outside, but you all know where to go. We're back at 11:25. Now I've got you all here, we'll thank the sponsors for this event, which is Optum, the Health Foundation, who've been supporting this event since its inception, MSD, Boston Consulting Group, and we have 2 media partners, BMJ and Guardian Health Professionals. We could do with more Twitter traffic, so those of you who tweet, please do. Remember the hashtag NT Summit. And let's just close by thanking Anastasia for her presentation. Thank you very much. Thank you.